Okay, let's unpack this. We are entering a niche, but wow, an incredibly high stakes area of occupational medicine today. We're talking about the world of the NRCME certification.
Right, that's the National Registry of Certified Medical Examiners.
And if you're a medical provider, an MD, DO, NP, PA, even a DC, and you want to perform those mandatory physicals for commercial drivers, well, this is your ticket.
It is, and our mission today really is to give you the shortcut, to understand not just the mountain of regulations, but the real logistical hurdles, and maybe more importantly, the philosophical shift you have to make to pass this thing.
The philosophical shift, what do you mean?
Well, you aren't there to treat a patient. You're acting as a gatekeeper for public safety. You're there to determine driver fitness for duty.
Ah, that distinction is everything, isn't it?
It's the whole ball game.
Let's nail down the basics right away because this isn't a one-and-done certification. It's a decade-long commitment.
It is. It lasts a full 10 years. But you can't just set a calendar reminder for 9 years and 11 months from now.
Right.
Recertification is required no sooner than 9 years, but no later than 10. So that's your window. And there's another catch.
Which is?
There's a midpoint requirement. You have to do refresher training every 5 years just to stay current on all the regulatory changes the FMCSA pushes out.
So, okay, if you're an eligible provider, where do you even begin? I'm guessing you can't just pay a fee and show up for the test.
Not at all. The first step is totally non-negotiable.
Hmm.
You have to complete an accredited training program that gets you your certificate of completion, which is basically your golden ticket into the system.
Okay, so you have the certificate. Then what?
Then you apply directly to the DOT FMCSA, and they give you a unique 10-digit national registry number. You need that number for everything that comes next.
And when you finally get to scheduling the actual test, what are the logistics there? I was actually surprised to see the fee is pretty reasonable. It's only $80.
Yeah, the fee isn't bad. The test is administered in person, by appointment, through third-party companies. It's mostly Prometric and PSI these days.
PSI. I thought it was Chimera.
It was. A little fun fact, PSI actually bought Chimera back in 2016. So if you see any old study guides mentioning Chimera, just know it's PSI now.
Good to know.
And thankfully, most locations do offer weekend testing.
Okay, security. It sounds like it's pretty intense, which I guess makes sense. What should you expect when you walk in?
It is totally closed book, all on a computer, and they ask you to empty everything from your pockets.
No?
No phones, no pens, no paper. They are serious.
So what do you need to bring?
3 things. Absolutely must have.
Yeah.
Your certificate of completion, a valid state-issued photo ID, and a copy of your current medical license.
And if you forget one of those?
You'll be turned away. Simple as that.
All right, let's talk strategy. You get 2 hours, 120 questions. That's a relentless 1 minute per card pace. Efficiency has to be critical.
It's a marathon, for sure. And here's a really crucial detail that changes how you approach it.
Go on.
Only 100 of those 120 questions are actually graded.
Well, so 20 of them don't count.
Exactly. They're pilot questions. The FMCSA is testing out for future exams. But the thing is, you have no way of knowing which is which. They're mixed right in.
So you have to treat every single question like it counts.
You have to. You have to answer all 120 with the same focus.
It's all multiple choice, right? 4 choices.
Yep, 4 choices, single best answer. The computer system is actually pretty good. It lets you cross out answers you know are wrong and, importantly, flag questions to come back to.
Which seems essential with that kind of time pressure.
Oh, absolutely. My advice is don't get bogged down on some obscure regulatory question early on. Flag it, move on, get the easy points, then circle back.
And the passing score.
71%. You get your score right away, which is nice, but don't expect that official certificate in your email for up to 3 weeks.
What if you fail? I remember hearing there used to be a really punitive 30-day waiting period to retest. Is that still the case?
That's a great question, and thankfully, no. They've improved that part of the process. There is no longer a mandatory 30-day wait.
So you can just reschedule immediately.
Well, in theory. The FMCSA has to get the failure notice and update your account, and they say that can take up to 7 business days. And that's where the new bottleneck is.
It sounds like the whole system is kind of groaning under its own weight right now. I mean, everyone who's certified in that first big wave back in 2014 is hitting their 10-year recertification now.
That is a huge part of the problem. We are seeing major credential verification backlogs.
So if your account isn't verified, you just can't schedule your test. And if your certification expires, you can't work.
Exactly. It's more than just a nuisance. It can stop you from practicing. This is why you have to be persistent.
So what's the insider trick? If you're stuck and can't schedule your exam, what do you do?
Don't wait. You have to call FMCSA technical support. The number is 617-494-3003.
Okay.
And here's the pro tip. When you call, use the prompt sequence 2, then 6. It bypasses all the long greetings and gets you to the right department.
2, then 6. Got it.
And at the same time, you should email fmctgsup@up.gov, hit them from both sides, and just keep checking the portal every day until it opens up.
Okay, we've covered the mechanics, but let's go back to that high-stakes concept you mentioned earlier, the philosophical shift.
Yes.
This sounds like the biggest hurdle for experienced clinicians, a physician, an NP. You're trained to maximize a patient's long-term health. But here, you're being asked to maximize public safety. How big of a change is that?
It's a complete 180. As a treating clinician, you might manage a patient with, say, mild hypertension. You put them on the best drug, you manage the side effects, you're aiming for their health in 10 years.
Sure.
The ME's role is it's purely binary. Is this person fit to safely operate an 80,000-pound truck for hours on end right now?
So you're not asking what's the best drug for this patient. You're asking, does this drug cause sedation?
Precisely. You're asking, does the regulation permit this? Not, is this clinically reasonable? And that's the trap. Because about 60 to 70% of the exam is straight regulatory knowledge. But the other 30 to 40% are clinical questions designed to catch you if you haven't made that pivot. A great clinician might pick the best clinical answer.
Which could be the wrong answer on the test?
Very often it's the wrong answer under FMCSA safety rules.
Which just hammers home why you can't rely on old study guides. If the rules change, your clinical instinct could actually hurt you.
You cannot overstate this. You have to use the definitive, most current source. For anyone studying now, that is the Medical Examiner's Handbook 2024 edition.
The 2024 edition.
It explicitly replaces every previous edition. It has critical updates to the medical advisory criteria. If your study materials are from 2022, you're learning old and potentially unsafe rules.
All right, let's get into the dense medical weeds here and pull out some of the highest yield numbers. I'd imagine cardiovascular health is at the top of the list.
It's paramount. The why behind the cardiac rules is all about risk prediction. They're really based on data like the Framingham Risk Score, trying to keep a driver's 10-year risk of a major coronary event below 20%.
And some conditions just automatically put you in that high-risk category, right?
Yes, things like diabetes mellitus or peripheral vascular disease are considered CHD risk equivalents.
So let's talk about the cardiovascular golden rules, the things you absolutely have to memorize. Where do we start?
The first one, the absolute floor for certification, is the left ventricular ejection fraction, the LVEF.
The heart's pumping power.
Exactly. It must be greater than or equal to 40%. No exceptions.
So LVEF of 40% or more. What else?
No pulmonary hypertension.
Right.
And the specific definition there is pulmonary artery pressure that's 50% or more of the systolic pressure.
Okay.
Also, no ischemic changes on a resting EKG and no angina at rest. And the driver has to show a capacity for 6 meets on an exercise test.
And what if a driver has multiple issues, like maybe they had a heart attack and also have an aneurysm?
Great question. The rule is, if multiple waiting periods apply, you must always wait for the longest waiting period to pass before you can even consider certifying.
That makes sense.
And one final rule for all cardiac conditions, no matter how stable, they all require annual recertification every single year.
Let's run through the most common waiting periods. These feel like guaranteed test questions. A driver has an MI, a heart attack. What's the downtime?
Minimum waiting period is 2 months. After that, if they pass a satisfactory exercise tolerance test in ETT and their LVEF is 40% or higher, they can be certified for a maximum of 1 year.
Okay, 2 months for an MI. What about something less invasive, like getting a stent put in, a PCI?
Much shorter. The wait is just 1 week minimum. But again, max certification is 1 year, and they still need to get a satisfactory ETT 3 to 6 months after the procedure.
And for the big one, the CABG, the bypass surgery.
That's a minimum 3-month waiting period, and you have to physically check that the sternum is healed.
How do you do that?
You test their resisted arm abduction and flexion. Post-TPG, they still need that LVEF over 40%, and they'll need an annual ETT starting 5 years after the surgery.
Let's shift to aortic aneurysms. This is all about size, right?
Size and location, yes. For an abdominal aortic aneurysm, a driver is disqualified or DQ'd if it's 5.5 centimeters or larger for men or over 5.0 for women.
And for a thoracic one, in the chest.
The DQ threshold is a little smaller, anything over 5 centimeters. And even if it's smaller than that, they still need mandatory clearance from a vascular surgeon.
Okay, let's wrap this section with diabetes, specifically insulin-treated diabetes, because the rules here have changed so dramatically.
This is where that 2024 handbook is absolutely essential. The current protocol requires the driver to have the MCSA 5870 form filled out by their treating clinician.
The person who actually prescribes the insulin.
Right. And the monitoring requirements are much stricter now, too. It's all about electronic proof.
What does that mean, electronic proof?
The driver has to provide at least the last 3 months of their blood glucose records, and they have to be from a device that stores the date and time and can be downloaded. No more handwritten logs.
They're trying to prevent people from just making up the numbers.
Exactly. And the immediate disqualifier is severe hypoglycemia.
Defined as?
If the driver's had any episode in the past 3 months where they required assistance, lost consciousness, had a seizure, or went into a coma, that is an immediate DQ.
But if they have the form and their logs are good, they can get certified for a full year.
They can. But there's one more little exception. If a driver is newly on insulin and doesn't have 3 months of records yet, the ME can issue a temporary one-time certification for no more than 3 months. It just gives them enough time to gather the required data.
Let's do a rapid-fire round. The common regulatory disqualifiers and red flags you have to know. Let's start with medication.
Okay, first up, opioids, like hydrocodone. This is a major red flag for sedation.
Is it an automatic DQ?
Not necessarily, but it requires the ME to get written notification from the prescribing doctor saying the driver is safe to operate a CMV. Without that letter, it's a DQ.
What about benzodiazepines like Xanax?
That's a very high DQ risk.
Yeah.
The sedative effects and cognitive impairment are just not compatible with commercial driving.
And what about drugs that are red flags because of what they're treating?
Good question. Antabuse is a specific DQ because it means the person is in current treatment for alcohol abuse. Chantix, for smoking cessation, is also a recommended DQ in FMCSA guidance, likely due to potential psychiatric side effects.
And the question everyone asks? Medical marijuana.
Disqualification. Period. End of story. Even with a state prescription, it's not approved by the DOT. Federal rules trump state laws here.
Moving on to neuro and mental health, the key seems to be waiting periods. What about a TIA, a mini-stroke?
1 year waiting period. Full stop. Same for a severe depressive episode or a suicide attempt. Minimum 1 year off the road to ensure stability.
And the rules for epilepsy sound incredibly strict.
They are. A driver can only be certified if they've been seizure-free and medication-free for 10 years. But here's the catch that trips people up.
Okay.
They also have to present current follow-up from a neurologist. If their last neuro visit was 13 years ago, even if they meet the 10-year rule, that's a DQ. You need proof of recent ongoing specialist monitoring.
Finally, what are some red flags from the physical exam itself that mean you stop right there and refer them out?
Okay, during the abdominal exam, if you feel a lateral pulsation above the belly button and you hear a bruit, you have to suspect a possible AAA, an abdominal aortic aneurysm.
And you do what?
You stop the exam. That's an immediate referral for imaging and maybe to the emergency room.
What about sleep issues? A driver who seems exhausted.
If you suspect new, uncontrolled sleep apnea, they're tired, they're snoring, they're having trouble staying awake, that's a DQ until they get tested. If they're already on a CPAP, they need to bring in their compliance reports to prove they're using it.
Got it. And just quickly, a couple of sensory standards. Vision.
You need peripheral vision of at least 70 degrees in at least one eye.
And hearing.
The hearing test is surprisingly low-tech. You have to perceive a whispered voice at 5 feet. And you only need one good ear to pass.
Last one. Musculoskeletal. After something like neck surgery.
Post-cervical spine surgery. A driver has to show at least 45 degrees of cervical rotation. That's to make sure they can physically turn their head enough to check their mirrors and blind spots. If they can't, it's a safety DQ.
Wow. This deep dive really shows that success here is a dual focus, isn't it? You have to master the mechanics of the test, but more than that, you have to fully adopt that regulatory safety mindset.
You have to. You have to internalize those critical numbers. The whole system depends on knowing LVEF has to be over 40%, that a driver needs 6 MNS capacity, and locking in those waiting periods, 2 months for an MI, a full year for a TIA.
Right.
It's really specific, high-stakes knowledge.
So here's a final thought for you to chew on. We spent a lot of time talking about how the rules for things like insulin-treated diabetes have changed so radically, making older study guides basically useless. Given that, how critical is it for an ME who's, say, 4 or 5 years past their initial training to be constantly reviewing the latest handbook, like that 2024 edition. They're making public safety calls every single day. The second a provider assumes that their knowledge from years ago is still good enough, they risk making a decision that could endanger the public or unfairly cost a driver their entire livelihood. This really seems like a certification that demands continuous regulatory education, not just every 10 years.